What's your sense of whether there are clinically significant differences among the first or second generation EGFR tyrosine kinases? That is, Iressa, Tarceva, Gilotrif or Giotrif. Are these agents that you consider to be really interchangeable? Does it matter what actual mutation the patient has? Or do you think it's really completely a dealer's choice? Ben, why don't I start with you?
Yeah, sure. So there's certainly differences at the clinical level. The second generation inhibitors, afatinib and dacomitinib, do have a lot more toxicity. They're very potent inhibitors of both mutant and wild type or normal EGF receptors. So skin, nail toxicities, diarrhea are more common with those drugs than with Iressa or Tarceva. In terms of the question of efficacy, I think we're all waiting to hear the results of a head-to-head study. It's very difficult to compare different phase 3 studies. But there is some interesting data that has been presented with afatinib from actually a couple of different studies, which admittedly was a subgroup analysis, which suggested that in the subgroup of patients that had exon 19 deletions as opposed to the group that had L858R mutations, there was a survival benefit. But it's not clear whether that same difference might have been seen in the other studies with the other drugs as well, if it was looked for in sufficient numbers. Mm-hmm. So to my mind, it's an open question about whether there's increased efficacy. I guess the other point Leora alluded to, occasionally you do see responses to afatinib in patients who've progressed on Iressa or Tarceva, which may suggest some differences in efficacy.
What's your thoughts on whether there's clinically meaningful differences between them and whether there is a significant difference between the main activating mutations for all EGFR TKIs or for afatinib?
So I completely agree with Ben that the toxicities are clinically meaningful and different between the different agents. Lux Lung 7 is closed to accrual, and
that's
so
a trial
hopefully
directly comparing afatinib to Iressa in EGFR mutation positive patients first line.
And it's primarily in Asia because gefitinib up until a few weeks ago was not available here.
I just learned that it's actually half Asian and half European.
Oh, okay.
Which will be helpful to know because we do struggle with the question of whether the results out of Asia are completely generalizable to non-Asian populations. Mm-hmm. Yeah, but so I think we're going to be getting the results of that in the first half, hopefully, of 2016, at least some of the results. And so that'll hopefully shed some light on this controversial question.